In part 2 of these presentations on safety theory and incident reporting and perfusion, we look at building into safety 2 concepts to our perfusion practice, safety 2 opportunities, if you will, and a fresh look at incident reporting and perfusion. With current perfusion technology, we're now in the unique position where we can build in resilience and resilient performance to our practice by acquiring automatically or electronically all of the information that occurs throughout a cardiopulmonary bypass. We monitor this and measure it, and if we use these data, we can then respond and anticipate to performance as we move forward. So a prime example of incorporating safety 2 concepts into measuring what went well during cardiopulmonary bypass is the use of collaborative registries. And the Australia-New Zealand Collaborative Perfusion Registry is one of a number of registries internationally that collect data from procedures, and we can see from the bottom left-hand graph that over a relatively short period of time, a vast amount of information and data can be accumulated, and this can be used for quality measures, for quality improvement, and linked to outcome and improvement of outcome. And what we are doing in terms of collecting these data is collecting everyday data of what went well. This can be used ultimately to produce publications in the peer-reviewed literature and drive change to practice with a view to improving outcome. We can see from the Australia-New Zealand Perfusion Collaborative Registry that the 7 or 8 centres can compare and benchmark their work that they do, looking at, for example, net primes and oxygen delivery index, and we can look at the best performing centres and ask them what are they doing that we're not, and how can we raise our game and improve our performance. Certainly red blood cell transfusion has been a focus over the years for quality improvement. We see on the left hand side some variation in practice variation in red cell transfusion by different centres, but over time on the right hand graph we have driven the use of transfusion down significantly over time. Another important aspect of understanding what goes well in cardiac surgery is culture, and we can't underestimate the impact that culture has on outcome of patients that are in our care. Dr. Carl Horsley is an intensivist with an interest in human factors and safety too at Middlemore Hospital in Auckland, New Zealand, and he was responsible for, as the title on the right says, turning safety on its head and building resilience into the everyday use by engaging the team at the front line at the sharp end to redesign how the intensive care was going to be run, rather than have this driven from a management policy procedures perspective. And by drawing on the expertise of people who were at the front line, they were able to radically improve the outcomes of their intensive care. Comparison and analogies between the operating room and the airline industry in terms of safety are frequently made in the literature. And in this paper by McGreevy and colleagues, they concentrated on fighter pilot crew resource management in terms of briefing and debriefing and the importance of that in the operating room, where the importance of briefing is relatively well understood in the cardiac operating room, but the concept of debriefing is less well executed. This really presents a safety 2 opportunity. The WHO safety checklist is ubiquitously used now in all cardiac operating rooms. And while we're pretty good at the timeout phase of the WHO checklist, which is analogous to the briefing for fighter pilots, the surgeon here goes through his expectations for the plan for the operation and completes the various checks that are on the checklist on the wall. We are less good at the debriefing opportunity, which would occur at the sign out, where really there is the time then to reflect on what went well and what could have gone better, and how we might improve our next performance in the operation. There are other examples of incorporating Safety 2 concepts into healthcare, and this website, Learning from Excellence, which was designed and run by Adrian Plunkett out of the UK, takes examples that have occurred where someone reflects on something that has gone really well and asks a number of specific questions with a view to be able to rolling this idea out to improve patient outcome. And while this is a fairly sophisticated way of looking at reflections on excellence, because it's web-based system and has peer review, it may be as simple as simply having a smart ideas book in the department. People constantly have very good ideas that are not necessarily shared widely or result in a change in practice. Safety opportunities also arise with incident reporting systems, and the question comes to mind, does incident reporting fit Safety 2 as well as it has been integrated into Safety 1 thinking, where we are actually measuring what went wrong? And in the Perfusion incident reporting system, we have introduced the Safety 2 concepts of good catch. And so we have adapted the WHO definitions for near miss and no harm incident as being good catch near miss and good catch no harm, as in either of these kind of situations, something has gone well that has precluded a further bad outcome. So in the description for the report form, we ask, in fact, what went well? What was the good catch that occurred in this near miss or no harm situation? And what could have been done better as a result of that? When we previously looked across New Zealand cardiac centres at reporting incidents and reporting trends and practices, the least reported incident was the near miss incident. And yet this presents the greatest Safety 2 opportunity. Data from the Perfusion Improvement Reporting Scheme, looking at incidents for the last 10 years to July of 2020, reveal that almost all of these reported incidents were either good catch no harm or good catch near miss. In the vast majority of these incidents, something went right to stop a worse outcome occurring. And the lessons from what went right in these incidents are in essence vaccines against badness. We can see on the right that perfusionists that subscribe to this reporting scheme are widely likely to discuss their situations or incidents within the team, somewhat less likely to file a report to the institutional reporting scheme, and only a very small number of these go to external authorities. But one should bear in mind that these are management errors or incidents that have occurred, and equipment type incidents would more likely be reported to external authorities. The other recommendation is that we report lesser severe issues that we might consider hassles. And if we talk about hassle stories, we're talking about work as done. They're not incidents per se, but they're the minor things where we learn from the workarounds that we applied to our daily work experience. We need, in fact, to concentrate on including accident theory into training programs. And safety theory has, until relatively recently, largely been absent from core curricula for perfusion certification programs, and that is now changing. So The effort really is to focus more broadly on aspects of safety for the cardiac operating room and perfusion in particular. And we don't want to look just at one end of the bell curve in terms of accidents and incidents, but we want to look carefully at the things that we do, the majority of performance that we're engaged in on a day-to-day basis that went well. It is not exclusive from one aspect to the other, but a combination of Safety 1 and Safety 2 concepts that will lead improvements. The Perfusion Improvement Reporting Scheme now has been updated to include all of the reports that have permission to publish, and these are not necessarily all of the reports that are submitted. These are available on the website and will soon be grouped by category to make research easier. And we also have human factors data that is current, and we can see what are the things that drive variation in practice that perhaps we could improve on. So finally, this recent paper by Luc Pouy and colleagues from the EACS group state, it is recommended to objectively report, adequately record and properly analyse all adverse events related to cardiopulmonary bypass practice in an efficient and timely measure, and this is a level 1 consensus recommendation. Thank you very much.